So back when I was studying midwifery, I did an internship in Uganda. And I really enjoyed working in a different way. I really enjoyed working there. I'm Belgian, so in Belgium as a midwife, we don't have the same freedom of work as in some other European countries. Well, very much in a system where everything is doctor controlled, which did not please me very much, and I got another freedom in that other work. And so I decided to do a postgraduate in tropical medicine for nurses and midwives, and then started working for MSF, Médecins Sans Frontières, Doctors Without Borders, when I was 24 years old. And I've done first a number of missions as a midwife, so longer missions between 6 months and a year per project in a number of countries, but mainly African. Like that, I've been in Liberia, I have to think very well, Liberia, South Sudan, Darfur, Central African Republic, Burundi, Pakistan, and Afghanistan. As a midwife, and then later as a project medical referent. Like that means the person who is responsible for all the medical activities in the project. And then I there's this thing in MSF where you grow up and you are like pushed to become, to go up the hierarchical lines. And I did not like that. Well, it's not that I couldn't do the positions, but I did not enjoy myself in my daily life. I want to see patients. So I got the opportunity to apply for a position that is mobile implementer for sexual and reproductive health, meaning that I am attached to the headquarters medical department, where we look at quality assurance and standards and protocol writing and all these things and trainings that we give. But my task is to go and support the projects on site, and do not for 1 week or 2 weeks, but like minimum 6 weeks per project, for specific reasons related to anything in women's health. So it can be maternity, deliveries, complicated deliveries, BMONC, antenatal care, postnatal care, contraceptive care, safe abortion care, post-abortion care, sexual violence, and all and everything that is around it. Prevention of mother to child transmission and HIV, anything that is related to pregnancy and sex, basically. I can give specific trainings, or I can set up new activities with them, or help them to improve on quality and these kind of things. So since 2013, I'm in that position, and that hasn't changed since. Mm-hmm. So I go to about 4 to 5 countries a year, or projects, and spend some time there working on women's health. So in that, I have also worked with refugees. I've worked with IDPs, meaning internally displaced people, which are refugees who did not cross the border of their country, but had to flee the place where they live, and also stay in camps usually. I've worked with the refugees in various settings, in camp settings, in South Sudan and other places, but also in Europe. So mainly in Greece and a bit in Belgium, but in Europe it's mainly facilitating access to healthcare, antenatal care, contraceptive care, safe abortion care, very important. As an organization, not everybody is of the same opinion in the public health world, but for MSF it's a choice. Everything is free of charge, so even the most vulnerable have access to the healthcare. Of course, most of our colleagues come from the same country, are from the same population. Sometimes we even employ refugees if we can. The bridge can be made, that cultural mediation can happen, that we can create a much better understanding of what our people are going through and how we can offer them the best care. And going there with an open heart, you'll come out so much richer and so much. It's beautiful. It's really beautiful work.